C'est un meilleur système de santé, je pense, à la fois pour les médecins, parce que les médecins en France, ils ont la totale liberté d'installation. Ils peuvent aller s'installer où ils veulent, il n'y a pas de restrictions. Ils peuvent travailler soit dans les hôpitaux, soit en privé, en médecine libérale. Il n'y a pas de restrictions non plus. Et sous certaines conditions, ils peuvent même pratiquer des tarifs libres s'ils sont installés en libéral. C'est-à-dire que c'est eux qui vont fixer le prix de la consultation. Tandis que les patientes, en France, ils peuvent aller consulter n'importe quel médecin sans obligatoirement passer par le médecin traitant. Ils peuvent aller consulter n'importe quel hôpital, que ce soit public ou privé, sans aucune restriction. Bien sûr, tout ça, ça a un coût, et même, vous allez voir tout à l'heure, un coût très important. Alors, qui c'est qui prend les décisions pour le système de santé en France ? Après 1945, après la Deuxième Guerre mondiale, en France, on a créé le système de sécurité sociale. Essentiellement, c'est la sécurité sociale qui prenait les décisions. Mais maintenant, plus en plus, c'est le gouvernement, par le biais d'une loi de financement de sécurité sociale tous les ans, qui détermine combien on va dépenser pour la santé. Le Parlement qui va voter cette loi, parfois, malgré le gouvernement, ils vont faire des amendements, ils vont changer, ils vont modifier un petit peu. C'est une des lois qui est votée, qui est très importante en France. Et la particularité en France, il y a des agences régionales de santé, comme les préfectures, qui dirigent les régions, qui vont dire dans quel hôpital, quelle activité on va faire. Éventuellement, c'est actuellement en cours, quel hôpital va fusionner avec quel hôpital, voire quel hôpital va fusionner avec quel hôpital privé. Donc là, nous avons un exemple, par exemple en 2012, le Parlement avait voté pour une dépense de 171 milliards d'euros. Combien de hausses et combien de cet argent va être dépensé par les hôpitaux, combien de cet argent va être dépensé par la médecine de ville, combien de cet argent va être dépensé pour les personnes âgées, etc. Alors, d'où vient le financement ? Essentiellement, bien sûr, ça vient de cette caisse particulière qui est la sécurité sociale. Tout à l'heure, je pense que Bojan Popovic, quand il va faire les résumés des comparatifs des différents systèmes de santé, et il y a deux concepts. Il y a le concept bismarckien et le concept de Beveridge. C'est-à-dire qu'en France, la sécurité sociale finançait les dépenses de santé par le biais des cotisations. Les cotisations sur les salaires et par l'employeur et par l'employé. Mais vous voyez que la sécurité sociale finance à peu près 75% et qu'il reste à peu près 11%, c'est les gens qui dépensent de leur poche actuellement. Alors la sécurité sociale, c'est énorme et ce n'est pas que la santé. Ils prennent en charge aussi la vieillesse, c'est-à-dire c'est la sécurité sociale qui paye les retraités. C'est la sécurité sociale aussi qui paye pour la famille, c'est-à-dire aide aux familles, allocation familiale, tout ça. Et c'est la sécurité sociale qui paye aussi le chômage pour les gens qui sont sans travail. Donc le budget de sécurité sociale s'élève à 624 milliards d'euros et c'est un tiers du produit intérieur brut. Comparé au budget de l'État, qui est seulement 1/6 du produit intérieur brut. Donc, sécurité sociale, vous voyez, c'est une très grosse machine. Je ne vais pas faire l'historique pour ne pas être très très long, pour vous dire qu'en 1945, après la Deuxième Guerre mondiale, c'est De Gaulle qui avait lancé la sécurité sociale. Il y a une date qui est très importante. Depuis 1999, en France, avec la loi de couverture médicale universelle, fait par Bernard Kouchner, tout le monde en France, même les gens qui n'ont pas de salaire, sont couverts par la sécurité sociale. Même les étrangers en situation irrégulière, c'est-à-dire ils n'ont pas de carte de séjour, à partir du moment où ils peuvent prouver qu'ils sont en France depuis 2 mois, ils sont pris en charge par la sécurité sociale. Tout le monde est couvert. Bien entendu, je vous avais dit, il y a un coût. Vous voyez, il y a 177 milliards de dépenses, 165 milliards seulement de recettes. Parce que quand il n'y a pas de suffisamment de croissance économique, quand il y a le chômage qui augmente, il y a moins d'argent qui rentre dans les caisses de sécurité sociale. Donc ça, c'est le gros problème. Alors les recettes, je ne vais pas trop détailler, mais viennent essentiellement des cotisations des employés et des employeurs. Les socialistes ont établi un nouveau système CSG, contribution sociale généralisée, depuis les années 80. Ça commence à prendre plus en plus d'importance parce que les cotisations ne suffisaient pas. Et il y a aussi les impôts et autre chose. Alors, cotisation sociale généralisée, contrairement aux cotisations, ils ne sont pas seulement sur les salaires, ils sont aussi pour le chômeur, ils sont aussi pour le retraité, ils sont aussi c'est-à-dire qu'on élargit l'assiette et on intègre tout le monde dans ces cotisations pour avoir plus de recettes. Donc, CSG maintenant, qui est aussi appliqué par exemple pour les gens qui gagnent de l'argent sur la bourse, à la banque, avec les locations des biens, etc., tout ça, il représente maintenant 20% de recettes de sécurité sociale. Et on invente tous les jours des taxes en France. Récemment, par exemple, on a inventé une taxe pour les boissons gazeuses comme Coca-Cola ou pour des produits comme Nutella, parce qu'on dit c'est comme le tabac. Plus les gens ils boivent ça, plus ils deviennent obèses, plus ils ont des problèmes de diabète. Donc, il faut qu'ils cotisent, enfin sur les produits. Donc, on cherche par tous les moyens d'élargir l'assiette pour augmenter les recettes. Bien sûr, il y a d'autres sources de financement. Alors, comment on partage ces dépenses de santé? Essentiellement, c'est les hôpitaux qui dépensent le plus. Vous voyez, 45% des dépenses, c'est les hôpitaux. 34%, c'est hôpitaux publics, 10% privés. Après, quand on dit médecine de ville, je vous ai dit, un médecin en France peut aller ouvrir un cabinet où il veut. Il peut commencer avec une convention avec la sécurité sociale à travailler. Et donc, c'est 25%. Les médicaments, c'est 25%. Il y a un des défauts, je pense, du système de santé français, c'est la médecine préventive. En France, on soigne le malade, mais on ne fait pas la médecine préventive, c'est-à-dire on ne prévient pas la maladie. Quand la maladie existe, on guérit. Donc, je pense que c'est pour ça que tous les indicateurs ne sont pas très, très bons. Donc, on va passer ça. En France, la particularité, c'est que, en plus, c'est historique, en plus de la sécurité sociale, presque tout le monde a une assurance complémentaire. On appelle ça en France des mutuelles. Vous voyez, en France, c'est 13%, en Italie, c'est 1%. Je pense que ça n'existe quasi pas, assurance maladie complémentaire. Et cette assurance complémentaire va pallier là où la sécurité sociale ne va pas payer, notamment pour les médicaments, pour les soins dentaires, etc. Tout ça. Vous voyez donc, la population est couverte en France, également aux Pays-Bas. 96% des populations ont, en plus de la sécurité sociale, une assurance, une mutuelle complémentaire. Donc, les différents modèles de système de santé, ça c'est Bojan Popovic qui va parler tout à l'heure. Les systèmes d'assurance maladie, comme un peu la France, c'est le système bismarckien, financement par cotisation. C'est France, Allemagne, Autriche, Pays-Bas, Japon, Suisse, etc. Et les systèmes nationaux de santé, c'est esprit Beveridge. Là, la santé est financée par impôt. Les gens, quand ils vont aller voir un médecin, ils vont aller à l'hôpital, ils ne vont pas payer pour être remboursés après. C'est directement pris en charge. Je pense que l'Italie est dans ce cas-là aussi. Et puis, il y a le système de marché États-Unis. Je pense que ce n'est pas un bon système, donc je ne veux pas détailler. Tout à l'heure, De Deutsch, il vous a montré un petit peu qui dépense combien. Vous voyez que c'est les États-Unis qui dépensent le plus. Ensuite, c'est Pays-Bas et France qui disent chacun, nous, on a le meilleur système de santé. Donc, pour avoir un bon système de santé, il faut quand même dépenser de l'argent. C'est une évidence. Ça, c'est par personne. Ça, c'est un tableau qui est intéressant. Les pourcentages des gens qui disent qu'ils ont renoncé aux soins parce qu'ils n'ont pas ni couverture sociale ni de l'argent. Donc, vous voyez, c'est surtout aux États-Unis, 33%. La France, ce n'est pas très, très bon non plus, 13%. En fait, ça concerne surtout en France les soins dentaires, parce que les soins dentaires ne sont pas bien pris en charge par la sécurité sociale. Et les mutuelles, il faut payer vraiment très cher pour que ce soit bien pris en charge. Alors, je vais passer un petit peu ça. Le secteur hospitalier en France, De Deutsch a donné quelques chiffres pour le Portugal tout à l'heure. Vous voyez, nous avons 2751 établissements, 427 000, enfin beaucoup de lits. 4% de population active travaille pour le système de santé. Il y a beaucoup d'hôpitaux. Je vais passer un petit peu. Vous voyez, là où il y a plus de lits, c'est-à-dire par habitant, c'est Japon, Corée, tout ça, ça ne veut pas dire que quand il y a beaucoup plus de lits, d'hôpitaux, on est mieux soigné. Mais ça ne veut pas dire que quand il n'y a vraiment pas de lits, Inde, etc., tout ça, on est bien soigné. Donc, OECD, c'est à peu près au milieu. La France aussi. Donc, quand on dit les soins de ville, en France, la médecine libérale dans le système de santé a une place très, très importante. C'est-à-dire qu'en ville, les médecins traitants, que ce soit les médecins traitants généralistes ou spécialistes, font le travail et les gens ne sont pas obligés d'aller à l'hôpital pour avoir une consultation. Pour faire une cartographie des médecins, on a à peu près 200 000 médecins en activité régulière. Si on compte aussi les retraités, on est à 220 000, mais ils ne sont pas tous actifs. Donc, actuellement, c'est toujours 56% d'hommes, 44% de femmes, mais ça change vraiment beaucoup parce que les jeunes, vous voyez, 58%, c'est des femmes. Et surtout, actuellement, dans les facultés de médecine, les élèves filles, à peu près 70%, parce qu'elles réussissent mieux le concours. À la fin de première année, il y a un concours, il y a un numerus clausus en France. Donc, bientôt, les femmes vont dépasser un pourcentage les hommes. Donc, les médecins généralistes sont en diminution, les spécialités en augmentation, aussi bien en médical que chirurgical. Donc, par 1000 habitants, la France, c'est à peu près 3, enfin, c'est au milieu, comme OECD. Vous voyez que c'est en Grèce qu'on trouve plus de médecins par 1000 habitants. Et on parle, quand on fait des topos comme ça sur le système de santé, on demande toujours dans différents pays combien gagne un médecin dans ton pays. Donc, c'est pour ça que j'ai mis ce diapo. Donc, vous voyez qu'un PUPH, c'est-à-dire un professeur des universités, commence à peu près à 5-6 000 euros et il finit à peu près 8 000 euros. Mais ça, c'est sans compter éventuellement son activité libérale qui a le droit de le faire dans son hôpital, 2 demi-journées. Médecins libéraux, c'est-à-dire ceux qui sont installés en ville, ils gagnent un peu plus de 6 000 euros par mois. Et les PH, les praticiens hospitaliers, ça c'est, si vous voulez, c'est les médecins qui font travailler les hôpitaux. Ils passent un concours, après ils sont nommés dans un hôpital, ils sont nommés à vie. Donc eux, ils commencent à peu près à 4 000 euros, ils finissent 6 000 7 000 euros, sans compter les gardes et tous les autres suppléments. Ça, c'est salaire net. Et un chef de clinique, c'est-à-dire un interne qui vient de terminer la spécialité, il commence à peu près à 2 000 2 500 euros. Donc là, il y a un exemple. Moi, chef, en moyenne, le salaire net, c'est 7 000 euros. L'assistant qui commence, c'est 2 000, 2 500. Et entre nous, il y a une sage-femme. En France, les sages-femmes gagnent très bien, ils ont un bon salaire, 2 500 à 3 000 euros. Ce qui est important ici, j'avais mis, parce que ça ne veut rien dire combien d'euros on gagne, c'est par rapport au salaire moyen, combien les médecins ils gagnent. Vous voyez que c'est en Belgique et je pense aussi aux Pays-Bas que par rapport au salaire moyen, les médecins ils gagnent bien leur vie. Là, on va passer consultation 1. Donc, bien sûr, dans le système de santé paramédical, c'est très important. En France, 60 000 infirmières, 48 000 masseurs, enfin, j'ai mis tous les gens qui participent aux soins de santé. Et vous voyez que c'est en Suisse qu'il y a plus d'infirmières. Et c'est en Grèce qu'il y a moins d'infirmières. Et il y a même moins d'infirmières en Grèce que de médecins. Ça veut dire que c'est important ce genre de tableau. Ça veut dire qu'une partie des tâches infirmières en Grèce sont faites par des médecins. Donc on conclut, nous, toujours par les femmes. Et espérance de vie, c'est Suisse qui est champion, on peut dire. La France s'en sort pas mal. Pour la mortalité infantile, si on prend pas Inde, Islande, tous les pays de l'Europe, c'est comme OECD. Mortalité par crise cardiaque, tout à l'heure, il a montré aussi de Deutsch. Dans le monde, c'est le Japon qui est meilleur, Japon et Corée. Et je pense que c'est plus par l'alimentation, ils mangent beaucoup de poissons, vous savez. Après, c'est la France qui arrive, c'est French Paradox, c'est le vin rouge, notre fameux vin rouge. Vous voyez que l'Italie, il est pas mal aussi, mais il est un peu plus bas. Ça veut dire peut-être que le vin français est meilleur que le vin italien, je ne sais pas. Et mortalité par maladie cérébrovasculaire, Suisse est toujours champion, France derrière, Italie, c'est pas mal non plus. Par contre, pour mortalité par cancer, dans le monde, c'est Mexique qui est le meilleur. Et dans les pays de l'Europe centrale, ils ont vraiment très mauvais chiffres. Je ne sais pas si c'est dû au tabac, Boyan, il va peut-être vous dire, ou je ne sais pas, vodka, non. Donc, je remercie toute l'équipe de la Fédération européenne de médecins salariés, Enrico Reginato pour son invitation et pour la région de Milano pour votre invitation. Merci beaucoup. Merci.
Non mi dilungo con altri commenti anche perché i tempi stringono, quindi invito a parlare Therese van Westende, che è la rappresentante olandese ed è una del direttivo dei medici dipendenti dell'Olanda. Quindi Teresa, it's your time.
Hello, it's a great pleasure to be here in Milan and to tell you this afternoon something more about our Dutch healthcare sector. My name is Therese van het Westende and I work at the office of the Association of Salaried Doctors, for short LAD in the Netherlands. The LAD is a trade union established in 1948 for employed doctors and pharmacists. We have over 25,000 members and we are still growing. Main reason for this growing figures is that the LAD has alliances with several professional associations in the care and cure. We operate on three main issues, namely working conditions, positioning and participation, and collective labor agreements. Okay, sorry. The LAD has an office with 30 employees situated at the center of the Netherlands in Utrecht. The Netherlands has been awarded the title of being the European country with the best healthcare system for the fourth time in a row. This is apparent from the Euro Health Consumer Index 2014 report, and this report has been published by the Sweden-based think tank Health Consumer Powerhouse since 2005. The study measured 35 national European healthcare systems based on 48 indicators covering the 6 areas mentioned on my sheet. The study has identified a secret weapon as the fact that the operational decisions in relation to healthcare are not made by politicians in the Netherlands, but by medical professionals. Plus, this is done with the patient's participation. ECHI feels many other countries can learn from the Dutch approach, but the excellent performance levels would be even more impressive with better cost efficiency. However, this doesn't appear to cause any problems as long as the Dutch people are prepared to pay for expensive care. The complete ranking of the Health Consumer Index is shown on this sheet. Other countries which are represented this afternoon are also shown in this ranking. You can see Italy in the middle, and Sweden and Germany represented at the top of the ranking. Based on this ranking, you may conclude that the wealthy countries have a better outcome in the index, but not all. Look, for example, at Italy, Spain, and also the United Kingdom. As you can see, in our country, there are many indicators with a good score, but there are also indicators with a negative score. For example, the smoking prevention, graded on the Tobacco Control Scale 2013, prevented us breaking the 900 score barrier. This is mainly caused by our rather liberal Dutch attitude, and other negative indicators are the direct access to the specialist and physical activity. The Dutch healthcare system works with a number of basic assumptions. First of all, the Dutch government guarantees that good quality healthcare is available and accessible for every people. This means that the health insurers are not permitted to refuse anyone for so-called basic insurance. This insurance covers all essential care which you as a citizen may need. This compensation will become applicable This compensation will become applicable once the citizen has paid his annual payments. The premium for the basic insurance package is not linked to an individual health situation, but will vary per insurer. The basic insurance package is compulsory for every citizen, and everyone will pay the appropriate premium. From a solidarity perspective, citizens with a low income will receive a financial allowance from the government for his insurance premium. The Netherlands has an additional 2 healthcare insurance packages in addition to the basic insurance package: the additional extra health insurance and the Exceptional Medical Expenses Act. This additional insurance is not compulsory. It's up to individual citizens to decide whether or not they want to take an additional insurance policy. This will give the citizen more security of extra care or reimbursement of certain medical expenses. The health insurance offers health packages, which means these insurers are in direct competition with each other. They decide on their own rates and tariffs and enter into contracts with healthcare providers like physiotherapists and hospitals. The citizen can decide for themselves which health insurer he wants to go with. The cost for this additional insurance will vary per health insurer. Plus, the costs for the long-term. Plus, the health insurer may also choose to exclude someone from additional insurance. The Exceptional Medical Expenses Act take care for the long-term cost for elderly people, chronically ill patients, and disabled people. Anyone living or working in the Netherlands is entitled to reimbursement this care and will pay a premium from this. This is done via the citizen's salary, and the premium is income dependent. The Dutch healthcare system is based on 3 pillars: the patient, the healthcare provider, and the insurer. The government is only responsible for the laws and legislation, but doesn't have a direct role in the healthcare process. The Dutch healthcare expenses have seen some significant increases over the last years. A total of 93 billion euro was spent on healthcare in 2012. For the Dutch citizen, this means an annual average of over 5,000 euros spent on healthcare expenses. The Netherlands spent 12% of its gross domestic product on healthcare spending. In this figure, care expenses are explained by income, demography, and value. As you can see, our GDP is almost the same, but our healthcare costs are significantly increased. This healthcare spending has been growing faster than our Dutch economy for many years. This has made it necessary for the government to intervene in order to manage these costs. There is plenty of ongoing discussion in this field. These discussions are mostly about the advantages and disadvantages of possible measures to limit the growth in spending, for example, by increasing the citizens' own contributions, by limiting the provisions included in the basic insurance package, or by organizing the health sector differently. Our 3 main expenses are the hospital care, the elderly care, and a rest group, with among others children daycare and youth care. You can see our increase also in this figure. There are 3 causes which made our healthcare expenses increase. Most important reasons are the expanded indicators, growth of patients, and technological development. Other causes are increasing prices and, as a relative small cause, aging. In 2011, our national healthcare cost 90 billion euros. In this figure, you can show how this amount of money is financed. At the left, you can see the main financial flow, our Contribution Health Insurance Act. Second flow is based on the Contribution Exceptional Medical Expenses Act, and the third is covered by taxes. Since 1972, our health care cost increased extremely, as you can see in this figure. In 2011, every Dutch citizen spent over 5,000 euros a year. Most money is spent on hospital care and only a small amount on general practitioners. Since 1972, the expenses for the citizens have also increased from 484 euros to 5,680 euros a year. So as told, the Dutch healthcare expenses have seen some significant increases, and we spend the most on the healthcare after the United States of America. The most important cause of these rising healthcare costs is the fact that more care is available and it's more easily accessible to. Illnesses or conditions which people used to die from are now very treatable. The improved healthcare means citizens are now staying healthy for longer, and they are also living a much older age, which means that the healthcare cost increases too. Plus, citizens now increasingly want to make use of all treatment possibilities and innovations. Inconvenience are accepted to a lesser degree, and much is demanded from healthcare and healthcare providers. Another important cause for the increase in healthcare costs is that the Netherlands invest in providing vulnerable people with assistance and guidance. However, these investments are currently appearing to be too costly, which actually resulted in cutbacks. We're constantly increasing, and we are expecting to see a strong increase in the years ahead. The quarter of the increase in healthcare costs is relating to aging people. To finalize, This debate is certainly not limited to the Netherlands alone, as many European countries are having to face up similar developments and therefore also similar challenges. We are not just taking a critical look at the affordability of healthcare, but also at the effectiveness of healthcare is also scrutinized. How many health benefits are being realized as a result of the spending? Could we have realized the same with less spending? Patients, healthcare providers, the government and health issuers are jointly responsible for top quality, accessible and affordable healthcare, also in the future. This demands flexibility with the healthcare landscape of all those involved, as well as in the finance structure which support this. Thank you for your attention.
C'era un punto che vorrei sottolineare a proposito di Olanda e Euro Health Consumers Index. Cioè, si considera nel lavoro della Euro Health Consumers Index che uno dei principali motivi per cui l'Olanda è ai primi posti come sistema sanitario è perché testualmente si sono liberati dei dilettanti, intesi come dilettanti politici, manager, contabili, esperti di organizzazione, mentre il sistema sanitario olandese è essenzialmente gestito dai medici. I consigli di amministrazione degli ospedali sono formati da medici dell'ospedale. Bene, adesso passiamo invece a Theo Merolz, che è il nostro collega tedesco. Devo dire che la Germania ha un vantaggio rispetto ad altri paesi europei, è in qualche modo, non voglio dire sovradimensionata, ma perlomeno ha una dotazione di risorse sanitarie che è più alta del resto dell'Europa. È un paese dove il numero di posti letto ogni 1000 abitanti continua a essere superiore a 5. È un paese dove c'è una forte carenza di medici e infatti c'è una discreta richiesta di medici da parte della Germania, con addirittura delle organizzazioni internazionali con l'India per attrarre medici indiani a lavorare in Germania. Quindi lascio la parola all'amico Theo e gli do quindi il...
Good afternoon, ladies and gentlemen. Thanks a lot for being invited to present the German healthcare system this afternoon here in Milano, a wonderful, a beautiful, fantastic city. Congratulations to everybody who lives there, who's a member, inhabitant of this wonderful city and region of Lombardy. Now, where's my presentation? Oh, you take this. Okay, this one. That was one. Okay, first one. Okay, here we go.
It's okay?
Yeah, it's okay. Okay, first of all, I want to give you an impression of my country of Germany, which is in the heart of Europe. The capital is, as you can see, Berlin, and our president, who's only a representative, like a king or like a queen, is President Gauck. And the head of government, everybody knows, even in Italy, is the Iron Lady of Germany, Mrs. Merkel. And we got a General Assembly in Bundestag like you have a parliament in Rome. And we got a similar structure like Italy. We got 16 states, would call them region here in Italy. These states are more or less autonomous in their decisions, but healthcare is federal. So most decisions concerning healthcare are done on the federal level. And we have about 82.5 plus X million inhabitants, because as everywhere in Europe, there are many people living in our countries who are not registered because they are illegal, sans papier. So we have maybe 85 million inhabitants now living in Germany. Okay, how do I progress this here? Like this? The German healthcare system is a gigantic part of the German industry. 4.3 million people are working in the health sector. It's even more now. In 2015, it's maybe 4.5 or 4.6 million people, which is much more than, for example, the German car industry employs. This is 10.6% of total employment, and about 50% are employed in hospitals, in inpatient care. We got about the same amount of doctors or physicians per 1,000 residents, per 1,000 inhabitants, like the Netherlands, like Norway, like Sweden, like the UK, or like the USA. We got about the same amount of nurses, like the countries I just mentioned, like the Netherlands, like Norway, like Sweden, like UK. Okay, like UK. And we got about 9,000 medical school graduates per year. And you already saw many numbers I'm going to present, so I can accelerate the process. We are in the top range of total expenditures related to the gross domestic product. So we are number 4 in this respect. We have place number 7 concerning the total healthcare spend per capita, which is quite the top range too. And low, you can see the total healthcare expenditures distributed by the sectors, like inpatient care, which is about 36.5%. Outpatient care is about 25%, and pharma, which is drugs and things like this, is about 17%. The rest is dental and others. So it's the same distribution like, for example, in France or in the Netherlands. The total expenditures I just showed, and I'm just showing you the growth of total expenditures between 2003 and 2012. And I show you also below the expenditures per capita. So there's a steady growth, like in Netherlands, like in France. So it's the same picture in those 3 countries, and I presume in many countries in Europe as well. But when you do this kind of comparison, when you compare expenditures ratio and the GDP, you can see that there is only a slow growth in rising healthcare expenditures. As expressed as a percent of GDP, it shows only a small growth. This is a very important message. When your GDP is growing, you can afford to spend more on health. Below you can see the distribution of the money spent in relation to certain groups of illnesses. Circulatory system, heart and vascular system, this is about 15%. Digestive system is 15%. Mental system is 15%. So half is, and the muscular skeletal system is another 15%. So these 4 big groups make more than half of all costs of illnesses spent in Germany. A very important thing is the German system of health insurance. Already the speakers before me talked about this subject. We have a Bismarckian system. Bismarck was a German chancellor in the 19th century, and in order to pacify the growing socialist movement in Germany, which was quite strong, remember that Marx and Engels were Germans, and the communistic or socialistic movement was very strong in Germany at that time. He tried to pacify the workers by introducing a healthcare system and a system for old age, which was at that time the first attempt worldwide to establish systems of that kind. So we got this Bismarck system, going back to Bismarck in 1884, which is more than 140 years now, or 130 years exactly. And this system is growing and growing and working and working. It was supposed to be a system for the poor workers only, but now it covers about 90% of the population. It's very similar to the Dutch system, or the Dutch system is very similar to the German system. We got those companies, those public companies, who are obliged to insure everybody who wants to be insured, and the premiums are proportional to your income up to a certain level. So this statutory health insurance system pays up to 60% of total health expenditures. It's about the same amount similar systems pay in France or in the Netherlands. Well, what about physicians? What about doctors in Germany? We got lots of them. We got 413,000, but actually working are 315,000, which is quite a number, but we got a big population, so they all find work. As Enrico just told you a couple of minutes ago, there's a big immigration of doctors to Germany because our numbers of young doctors is not enough to cover all positions in hospitals and outpatient treatment. Below you can see a distribution of our doctors. I presume it's the same in all countries of the same size like Italy or France or UK or so on. Well, this is the diagram, the slide which shows the distribution of medical specialists. You can see that about half of all doctors are not specialized, and more than about 55% are specialists like internal medicine, surgery, anesthesia, and so on and so on. Below you can see the type of education we have, which is more or less the same like everywhere in Europe. You got 6 years of medical studies, which is according to the norm, to the decrease of the European Union. And after 6 years, you are a doctor, and then you can start specializing. And this specialization lasts minimum 4 years, up to 6 years. And if you want to specialize, subspecialize, it lasts even 2 more years. So it's maybe up to 6 to 8 years altogether. Then you are a specialist after a board certification, which is quite strict. And then you can move on, either in hospital or you can open a private practice where you can work independently. Now I have to change. Somebody help me, please, from the technical side. It's a different.
You have the sound one.
Go back to this. No, it's number 2, this one. Okay, so we have some time. Yeah, this is exactly the same. Okay, start, please. This is correct. So we had some time to digest all the many facts I just presented, and we go back to German medical faculties, where our young doctors are taught, educated. And you see that there are many faculties, about 36, 34 are public, run by the state, by the states, and 2 are private. And we only produce about 9,000 doctors, which is about 3,000 too few. So we need 3,000 doctors more every year just to fill the remaining the positions we have open in Germany. So you see the slide up, and you can see that we produced what we had about 11,500 people leaving university, graduates in 1993, which was just after the reunification of Germany. When you remember, you know that Germany was 2 states up to 1890, West Germany and East Germany. And when the 2 countries, the 2 states were reunified in 1990, we believed we had a surplus of medical schools and medical students, so we cut down. And now we only have about 8,700. And as I already told you that this is about 3,000 too few. So we are going to change that slowly, but it takes a long time to rebuild universities and faculties once you cut. Well, what about physicians' income? You already saw the same slide, and it's a very interesting slide because it demonstrates the relationship between the median income of a population and the median income of specialists and general doctors. And it doesn't really matter whether you are 7 times better than the average or 5 times or 3 times better. It's never enough. That's the message. But this is, I think, human because everybody wants to make more money for working more and more time. Well, we have a big ambulatory care sector which is composed mainly of self-employed independent doctors. We have about 73,000 single-handed practices, one doctor, one practice, and only 19,000 group practices, which employ about 45,000 physicians. So the majority of all self-employed, independent, liberal doctors are single-handed, are in single practices. Now we have an absolute free choice of physicians, like in the Netherlands, like in France. No, like in France, not in the Netherlands, I believe. And we have about a large number of physician visits per annum, per year, which is about 10, which is much higher than the average in Europe, because you don't pay for the visits, you just go there. You pay your money, you have to pay for the insurance, and that's it. And then you can go to any doctor as often as you want. There's no limit. So we got a high number of people going to a doctor just for a checkup, just for talk, just for some support. And this is really a burden for the practices, for the offices, because they have many, many contacts where they just talk and try to satisfy and pacify the patients. We have a very high average good number in the free choice of physicians, and our waiting time for specialists is not zero, but very low in comparison to the rest of Europe. So you can see that we are on a good way. We're in the top range of Europe. The hospital sector is very huge also. We have about 2,000 hospitals, but this number is decreasing because we're doing the same thing like everywhere else in Europe. We are shutting down hospitals, small hospitals. We are doing concentration of hospitals and all the same things you already heard about this afternoon. We have about 70 million patients per year, which is 1/5 of the population. So every fifth German goes to hospital once a year, which is an astonishing number, even for me. I'm a hospital doctor, but I'm always surprised to read those numbers. We have about 1,200 rehabilitation facilities, which cover about 2 million patients. This is tertiary care after the secondary care of hospitals. Well, we do have quality management to manage this whole system. It works relatively well, but it can always be improved. But this is the main topic right now, quality management. We're talking about this, and we're implementing this for years, and I'm sure for years to come. One word concerning the providers of inpatient care. The private sector, this is concerning hospitals, is about 30%. The non-profit sector, which is traditionally provided by the churches, by the Catholic and by the Protestant church in Germany, is about 30% too, and the public sector, which is the states or the cities, is about 40%. You see that there's a change. The public sector is decreasing, is going down, and the private sector is going up, because private companies are demonstrating and demonstrated that they can provide good care, efficient care, with less money than the public hospitals. For people who work in the public hospitals, this is not such a good message, but it's more or less the picture in Germany. Well, we do have lots of hospital beds. We got 8.3 in comparison to Japan. They have 13.4, or in comparison to the United Kingdom. This is the lowest country, Großbritannien, that's United Kingdom. They only have 2.8 beds. And the general numbers of mortality, infant mortality, and old age and all that, they're all about the same. So a big number of hospital beds per 1,000 inhabitants doesn't guarantee good results. It's a way the system is built. You know, all those systems like the German system or the British system, they are all very traditional, and traditions do vary very much in Europe. So this is the result. Well, another special thing you might have heard about. This is the DRG system. We only get a certain amount of money for one patient in the hospital. And if the hospital succeeds in treating that patient well with the amount of money it gets per case, it makes money, or at least it doesn't make a loss. But if you don't succeed in getting enough money for providing the care you provided, you are in a bad shape. You are making not enough money, you are losing money. This is a very complicated system. I'm not going to talk about it because this is going to fill the whole afternoon. There are strengths and weaknesses. We have it for about 12 years now. It's working okay. So I'm sure we're going to keep that because there's no alternative. And once again, you see that hospital expenditures are growing every year, higher and faster than all other expenditures, but this is the same all over Europe because hospitals are very expensive because they treat people by people. Well, the length of stay is declining. Same phenomenon all over Europe, in Germany too, because this DRG system motivates to cut down the length of hospital stays. The patient goes out much earlier. And what is the result of all this? I'm going to sum up. In 2014, we had a good place number 9 in this Euro Health Consumer Index you already heard about, which is quite okay. We could do better, but this is an incentive to better our system. And our outcome scores were better in 2008. We had number 6, but you know, we had a crisis too in Germany, and this did have an effect on the treatment of patients on our healthcare system too. So we only had number 9 last year. But this is quite okay comparing us to other big countries like Italy or France or UK or many more. What are the problems? To sum up, we have an aging population, demography. We have an advancement of healthcare technologies, expensive treatments and pharmaceuticals. We have an increasing expectations of the population. They expect you as a doctor, as a physician, to repair anything. They consider themselves like I say sometimes like a car. When a part is broken, you fix the part and then you are new. But the human being is much more complex than this. But many patients in Germany expect that they are repaired like a car perfectly, and well, it does cost money, but they expect the perfect treatment. Then we have a decline in contributions because we did have the same crisis everybody else has had and still has, but now it's picking up again, so this is getting better. And then I already told you that we have a deficit of doctors and a deficit of nurses too, because these professions are demanding. You have to work a long time, you have to work long hours, it's hard work, and the pay is okay, but not the best in the world. So we have to work on those factors to keep our place, and we should try to make it even better. And I'm sure we're going to succeed and we're going to be successful. And in the end, thank you for your attention. And one last picture of my hometown. We got the typical medieval German castle up in the mountains, close to my hometown. Thank you.
Proseguiamo da ovest verso est e quindi adesso è il momento di Thomas Zilling, che è un chirurgo svedese ed è un vicepresidente della MH e ci farà la sua relazione.
Thanks, Enrico, for this nice invitation to share with you some aspects on the Swedish healthcare system. I have chosen to give my presentation a subtitle, From Spend, Spend, Spend to Save, Save, Save. And this is particularly for those of you who are politicians here today. First, some words about myself. I'm a consultant surgeon and associate professor at the university in Lund in southern Sweden. And the conflict of interest regarding this speech, there are none. So, what do I want to discuss with you? First, I want to compare a little bit between Italy and Sweden, and you will find there are a lot of similarities. I will talk to you about the Swedish system, how it works, the Swedish law with the patient's right of 70, 90, 90 days. I will talk to you a little bit about long-time financing, which is very important, and then about cuts in the Swedish healthcare system. So, when we compare Sweden to Italy, the climate in Sweden is very cold. That means that even though it's a very big country, we're not so many living up there. We're 10 millions compared to your 60 millions. But when we look at how many who lives on each square kilometer, we're only 21 compared to 200 here in Italy. But we spend almost the same amount of the gross national product for healthcare, 9.4% in Sweden compared to 9.1% in Italy. But our economy is a little bit stronger, so we use about $4,000 per person a year for healthcare cost compared to $3,000 in Italy. If we look at Sweden, it looks very similar to Italy. It's a long country, it's a narrow country, and we have a rich part in the southern and middle part of Sweden, and a much poorer part in the northern part, where we have the last wilderness in Sweden. And here you can see the river of Laponia. And on this picture, it's for miles and miles, and you will only see bears and no people at all. So, when we compare the healthcare sector, we will find that there are the same amount of doctors in Italy as in Sweden. 4.1 per 1,000 inhabitants in Italy and 3.9 in Sweden. But regarding nurses, the figure is totally different. In Italy, you have 3.3 nurses per 1,000 inhabitants. And in Sweden, we have almost a double, 11.1. And I've thought a lot about this because I need nurses around me, and we are lacking nurses in Italy. And I have one thought about this, that task shifting in Sweden is much more advanced than it is in Italy today. So, how does this system work in Sweden? We have three main players. We have the Swedish government, who only creates the laws. Then we have the National Board of Health and Welfare, which is very, very important in Sweden. It monitors and provides directive for the healthcare in the country. And then we have the 21 county councils, who are the performers of the healthcare in Sweden, and who also have the right to tax the inhabitants in their area. So this is how Sweden looks when it's divided into the 21 county councils. And you can see here that the inhabitants number varies largely. We have small county councils, the smallest with only 60,000 inhabitants, and then we have the Stockholm region with 1.9 million. And each of these regions are allowed to taxate the population. So, what is the Swedish system? It's a taxpayer-funded system, and everyone has equal access to care according to the Swedish law. And to fulfill this, the different county councils will have to pay, to charge different taxes from their inhabitants. Sweden is also divided into 6 healthcare regions, and each healthcare region must have at least one university hospitals. And the university hospitals, they provide education and research, which is financed by the government, although the healthcare which is provided within the university hospitals are paid by the county councils. So, back to the National Board of Health and Welfare. A very important issue for them is to issue specialist diplomas. There are no chamber, like is very common in many other